Right. Okay. So today we're talking about upper limb plan A blocks, which is interscalene and axillary block. So I'll start off with interscalene block. And to start off with interscalene, we have the image for a supraclavicular block. So I'll cover that at the start at the same time. So what you're looking at currently is I'm looking, as you can see, I'm looking behind the clavicle, and what I'm imaging at the moment in the center of the strain is the subclavian artery, which you can see nicely pulsating, and the bright white line immediately behind the subclavian artery is the first rib, and that's a starting point for both supraclavicular and interscalene block. Now, since we are here, we'll talk about supraclavicular block as well. Now, the left side of the screen is lateral, and the right side of the screen is medial. Now, as we know, lateral to the artery is the brachial plexus. You can see the honeycomb appearance of the brachial plexus is all the nerves. Now, at this level, the brachial plexus is the trunks becoming divisions. So this is also known as spinal of the arm. So essentially, the three trunks are there, and they're becoming divisions at this point. To approach to do this block, the needle comes from the left side of the screen, and we are aiming to get under the plexus, and then just to make sure, as you can see, the rib is there. And if I go a little bit lateral, you can see the bright white line. This is the lateral pleura. If I go a bit more medial, you can see the medial pleura. So you're very close to the lungs. So that's why this block is not that commonly performed for the same reason. Having said that, if you get a needle near in the corner pocket next to the artery in the rib, if you put some local around it, it just lifts the whole thing, and you can see the three trunks separating out, and you can block all the three trunks with the local at the same time. Going to the interscalene, as I track it up, I'm going to move the probe up slowly. Just keep an eye on the plexus, what happens there. So the lower trunk is just going to go away now, very quickly, going away now. And as you keep going up, the middle trunk is coming up in the view there, and I keep going further up, and the upper trunk is just forming now. So if you can see the two scalenus muscles, that's medial scalenus, anterior scalenus, and as I'm going up, so that's one nerve root there. That's a C6 nerve root forming. You can see a big transverse process of the C6 nerve root that go further up. That's a C5 nerve root forming there. Okay, coming down, C5, and the C6 is coming. The C6 has sort of two sort of circles when they say traffic lights, so C5 and C6. So for interscalene block, that's the image you want. And when we are approaching the block, you get the needle from the left side of the screen and aim to come posterior to the upper trunk and aim for the needle somewhere in the middle, and you inject the local. The local should normally spread around posteriorly, and some of it will go anteriorly as well. If not, you can actually target it around it or behind it. Now, interestingly, you can see a nerve structure just on the anterior scalenus muscle. This is the phrenic nerve. As you can see how close it is to the C5 nerve root. That's where it comes from. So if you're doing interscalene block, you're more likely to get phrenic nerve in 100% of cases, unless until you actively look to avoid it. So this phrenic nerve, anterior scalenus, medial scalenus, and that's your traffic light sign C5 and C6. Anything else I can see? So this is the sternocleidomastoid muscle on the top, and the cervical plexus lives just underneath it. If you want to put a block supraclavicular nerve. Okay, so just scan again, and just to mention, keep an eye on the upper trunk. As I'm coming down the upper trunk, there's a nerve coming off the upper trunk, suprascapular nerve, which is what you will target if you want to avoid the phrenic nerve. So if you can block this nerve, it would further away with 5 to 7 mils of local anesthetic. You can avoid doing interscalene block, and you still can give nice analgesia to your patients without worrying about the phrenic nerve. Okay, so that is going up again. So middle trunk, upper trunk, C6 and C5. Right, that's the interscalene done. We'll move on to the axillary block now. As mentioned, axillary block is mostly for distal branches of the local anesthetic. We'll put some more gel there. Now, as a convention, we keep the biceps on the left side of the screen. So looking into the axillary fossa, the landmark is the axillary artery and the conjoint tendon. So you can see the axillary artery in the middle of the screen there, and that's the conjoint tendon of the lat dorsi and teres major. And you can see like a clock. So if I'm looking artery as a clock, on sort of 11 o'clock position, you can see the median nerve. Over the conjoint tendon is the radial nerve, and the ulnar nerve lives somewhere around. So if we scan distally, keeping an eye on the structure there, you can see the ulnar nerve becoming a bit more visible at this point now. You see that? So if I track it back up, you can see that now. So ulnar, radial, and the musculocutaneous, and sorry, the median nerve. Other nerve is the musculocutaneous, which is important. So if I'm looking on the screen, you can see a bright white hyperechoic structure between the bicep and the coracobrachialis, like a diving fish. And that's the musculocutaneous nerve, which is very important for any surgery, especially with the tourniquet use. So how do we approach it? So you get the needle from the left side of the screen under the artery, and we get the radial nerve first, because that's a big chunky nerve, and that takes a while to block. And then you can come back and do the median nerve, and then go over the artery and get the ulnar nerve sitting there. And on the way back, you can come back and get the musculocutaneous separately around both anterior around the nerve. And that's the axillary block done. Okay, thank you very much.